Looking at the side furthest away from the image receptor. To visualize the zygapophyseal joint, in a C-spine, it's in a true lateral position. Okay? All right. So we got to relearn our landmarks. Relearn, right? Because we didn't use a lot. We haven't used a lot of these landmarks in a long time. So we need to relearn it. We need to understand these landmarks to find the different parts of the vertebral column. So your xiphoid tips level of T10. T7, how do we find T7?
This.
Okay, remember this, which is approximately 6 to 8 inches below what?
C7.
C7. Okay, the vertebral prominence of C7. So T7 takes you mid-thorax. Sternal angle. What is the sternal angle? That's the area between what part of the sternum?
The manubrium and
the
xiphoid,
gladiolus or the body, right? So that's your sternal angle at T4, T5. Sternal notch or jugular notch. Okay, aren't we also use that for chest X-rays, right?
For doing AP.
Or are you guys eyeballing it?
We got good eyes these days. Yeah.
Sternal notch, T2, T3. Okay, and then your vertebral prominence of C7, that is the area of C7T1. Okay, C7T1 is your vertebral prominence. Okay.
Hold on, please.
Pardon me?
Wait, please.
Oh, wait, okay.
Oh, thank you.
You're welcome.
Freaking retarded.
We need to upgrade our model.
Yeah.
Yeah.
Get up there, Nick.
Nah, I'm good.
Why? He's kind of beefy.
Yeah, it looks good.
Are you okay with the face?
No.
He's a butterface. It's okay.
Well, I can cut and paste.
He can
Go ahead, put your face
he
in
can
Put my face
he
up.
can Photoshop it.
All right, topographical landmarks. Okay, so sternal notch is at T2, T3. Vertebral prominence of C7 is at the level of C7, T1. The thyroid cartilage, you guys need to highlight this because the thyroid cartilage is a main landmark that we use in C-spine. Okay, so thyroid cartilage is at the level of C4, C5. Another landmark that we use a lot for the C-spine is the gonion. What is a gonion?
Point,
The
angle.
right? The angle of your mandible. So this is another one that we use, which is at the level of C3. Okay, those are the two main landmarks that we use for C-spine. The other is mastoid tip, which is C1, and then your EAM, which is at the EAM.
It makes sense.
Okay. All right, questions. All right, so again, the two main ones that we use is the thyroid cartilage, C4, C5, and then gonion is C3. Okay. All right, some pathology. There's not a lot here, so
Yes,
let's just go
thank you.
through them quickly. HNP, another word for your herniated disc, but more specifically, it's the herniated nucleus pulposus. Okay, HNP. So again, that's where the center, the nucleus, protrudes through the annulus and impinges upon the spinal cord. Okay? All right?
Okay.
Okay. Clay-Shoveller's fracture. It's an avulsion fracture. What is an avulsion fracture?
Where the ligament pulls the
It's where
bone.
the ligament pulls on the bone and causes it to fracture and separate. This is called a Clay-Shoveller's fracture because I guess back in the day when people used to shovel clay, this type of movement, and the tensing of the back pulled on the neck muscle, causing the avulsion fracture. Okay, so this is an avulsion fracture of the spinous process. Usually occurs at C7. Compression fracture. Compression fracture causes the vertebral body to be, this is just an example. There are many types of compression fractures, but here specifically we're talking about a compression fracture of the body of the vertebrae, causing a wedge shape. Okay, this can be due to trauma, very, very common in osteoporosis, and also occurs with metastatic disease where the bone becomes very degenerative, it loses a lot of bone mass, it becomes weak, and the body cannot support that weight, causing the body to compress. The body of the vertebrae to compress. Teardrop burst fractures caused by a severe, which is hyperflexion, chin down or chin up?
Chin up.
Down.
Hyperflexion. This is hyperextension. Okay, so hyperflexion. Okay, vertebral body is comminuted with probable damage to the spinal cord. Where's the spinal cord, by the way? Okay, because the spinal cord is formed by the pedicles and the laminae, right? So the spinal cord is going to run right through here. So what I'm trying to get at here is you may have some fractures to the body, and it's okay, because the vertebrae is still basically still stable, can be stable, because the spinal cord is over here. You can have a fracture of the spinous process and still be okay because the spinal cord is over here. Okay, but now if you have a fracture here, which extends towards the pedicle and then also the lamina, now you can have some issues. Okay, because how many of you guys have done C-spines and C fractures at the body or seen fractures at the spinous process?
not
You haven't
yet.
seen those yet?
Mhm.
Oh, okay. You will in time, okay? But it can be caused not by accident or trauma, but can be caused through degenerative disease like arthritis, old age, okay? But you will see those fractures, and it's common, and it's okay. Sherman's disease. Sherman's disease is a disease of the upper back, okay? Normal round back in the upper spine, also called kyphosis. Most people with Sherman's disease will have an increased round back, okay, or hunchback. I have an uncle like this. He's probably like 4'2". It's because of that. So he has a extreme kyphosis and he has a hunchback. And I haven't seen him like actually almost like 30 years. I thought he was dead. And I kid you not, I went to a funeral and I thought I saw a ghost. It's like I was looking at him like, I thought you were dead. And he's still walking around with his hunchback. You know? So this is Sherman's. Any questions here? Scared me. Spondylitis. Spondylitis is inflammation of the vertebrae, or more specifically, inflammation of the intervertebral joints. That's spondylitis. Okay, short and simple, short and sweet. Ankylosing spondylitis is an inflammatory condition where the spine may become rigid and fused. It begins, bless you, it begins at the sacrum and can work its way up towards the spine, but it usually starts near the sacrum. Bless you. Okay. All right. You see anything unusual about this AP lumbar?
Yeah, it was going through the center joint.
Okay, other than it looks like it's fused, but do you see that there is an increased density? It's really, really wide. Okay, yeah, so there's an overproduction of some bone going on over there. And there is some fusion because you're not seeing
Any
the
space?
spaces in between the spine. Okay. All right, Hangman's fracture. Fracture of pedicles of C2. Hangman's fracture. There have been some cases where the individual does have a Hangman's type of fracture and they're alive, they're not paralyzed, they're living and breathing and doing very, very well. Okay? But in most cases, it's bad.
All right.
Okay? If you're not dead, then you're paralyzed. Jefferson's fracture, take a look at that. You have an anterior and posterior fractures of C1 caused by landing hard on your feet, okay, because you have, you know, the head bounces on, that bone causes it to fracture, or going head first. This type of fracture is common where?
Swimming, diving.
Swimming and diving, yeah. Common in Hawaii.
Cliff diving or what?
Yeah, this is the most common type of trauma that they get in their hospitals because you got people seeing a wave and you're just diving right into it without realizing how shallow the bottom of the water is, and they just smack right into it, and they break their neck. This is the most common type.
What about base diving?
About what?
Base diving from, way.
Oh yeah, I don't know, how do they do it? Yeah, base diving, yeah, sure. Like, talking about the cliff divers of Acapulco? Yeah, I don't know how they do that. But yeah, they can cause that type of fracture. Okay, Jefferson's fracture. Oh, we did that already. Scoliosis. So scoliosis is a extreme lateral curvature of the spine, as we said earlier. If it's anything less than 10 degree angulation, that's pretty normal, but anything more than that, then it is considered scoliosis. So about 20 degrees is mild, 25 to 45 degrees is moderate, and anything greater than that is severe. So how do they correct that?
Infused.
Yeah, so they're doing the rods and screws, right? Okay. So again, depending on the curvature, they may or may not intervene. Spina bifida is where the backside, so the lamina, spinous process, there is no bone there, so it does expose the spinal cord. So there's an example of a child with spina bifida. This is a pretty extreme case. And then ultrasound, you see the spinal column here, and then all of a sudden there is no bone here. Spondylolisthesis. This is what I was trying to say earlier. Spondylolisthesis. It's a forward movement of one vertebrae in relation to another, may be caused by development defect of the lamina or the pedicles. Bless you. But it generally affects the pars articularis. That's why I had to put that up there on the previous slide, because it generally happens at the pars. So when that breaks, when there is no support, it's going to cause this vertebrae to slide forward. Okay. Breaks right here. Spondylolisthesis. Okay. Spondylosis. Spondylosis is a broad term meaning degeneration of the spinal column from any cause. In the more narrow sense, it refers to spinal osteoarthritis. So this is what I was talking about. You will see things like this, where there is, looks like there's some changes at the body, and there is parts of the body that is fractured. And that's, again, that's normal, usually due to age. Chance fracture. Chance fracture is caused by hyperflexion of the back, okay? Hyperflexion of the back, okay? Fracture through the vertebral body and includes the posterior elements. So through the body and also the posterior parts, which may include the pars or the laminae. Have you guys seen or heard of a laminectomy?
Mm-hmm.
So what's the, did you have one?
I've seen one.
Oh, you've seen one. Okay, so what's the whole purpose of a laminectomy?
They put rods in for support. They
Uh-huh.
take the lamina off and grind it up and
Okay.
get in, and then put rods.
Okay, so the whole, yeah, so yes, so you're putting rods. What they're trying to do here is that someone who may have a bulging disc, okay, or there's some reason where there's some impingement of the spinal cord from this area, they'll remove the laminae to allow the spinal cord to be a little bit more, allow it to breathe a little bit better, so to speak. Okay, so that's what the laminectomy is for, is to release any type of pressure and remove some pain or numbness in the lower extremities. So they remove the lamina. Okay, odontoid fracture. Yeah,
Damn.
Can't rotate his head, huh?
I don't think so. But I have seen some fractures where the dens is intact, and what is missing is the tip, and it's stable. And again, prognosis is usually good, even if it's just a fracture of the tip. Now, if you have a fracture here, now there may be some issues in stability. Okay, and then you guys can go through this on your own. Okay, I'm not going to spend some time on that, but you can go through that on your own. Has Ms. Mintz talked about myelograms?
Not yet.
Okay, she will, so I'm not going to
Yeah.
spend any time on that, myelogram. So, well, I'm just going to introduce you. Basically, what a myelogram is, they go with a spinal needle in your back, okay? Very, very similar to that of an epidural, okay? But instead of injecting medication or steroids in your spinal cord, they're injecting contrast. So you see an outline of the myelin sheath of the spinal cord. So this helps them visualize the different roots, nerve roots, coming off the spinal cord to see if there's any problems there that's causing your pain or numbness. Myelogram. Okay? So what they'll do is they'll inject contrast in either your back, in your neck, your back, or your lower back, put contrast in there, take some radiographs, and then they'll send them to CT to do a more precise study with a contrast. Okay. All right, questions? Okay, so let's go ahead and let's just fly through the positions for cervical spine. Routine, and these I don't know why it's in this order, but routine for cervical spine is what?
Lateral,
Well,
AP,
okay,
P,
AP,
lateral 2 obliques,
lateral, oblique,
and odontoid.
and odontoid. Why would we do swimmers? Isn't that the same thing as lateral?
Get the
Okay,
shoulder out of the
so
way.
You can't see C7, okay? So the objective is we want to see all the way from C1 to C7, okay? And most of those views, you're not going to see C1 through 7 in its entirety. That's why we have all these multiple views. All right? So things to consider. 60 to 72 inches. Why not 40 inches?
It's a lateral. Everybody get it all the time.
And there's increased OID.
Okay, well, that's what I was looking for, is the increased OID. Look at your neck. Okay. Even with me leaning all the way up, there's still going to be a gap. If I'm doing a lateral, now I'm about 6 to 7 inches away from the image receptor. Even when I'm doing an oblique, whether it's this way or this way, I'm still about 6 to 7 inches away from the image receptor. So we bring back the tube to decrease magnification, and when we decrease magnification, what are we improving?
The detail.
Detail. Okay, good.
But on APs and odontoids, we shoot them at 40.
You can do them, yes, you can do them at 40. So Nick just says, well, odontoid and AP, we do it at 40. Yes. But what you will also see in practice is that once they keep it at a certain distance, they leave it at that certain distance. So they can start off at 40. It's too much of a pain to go from here
Oh yeah, it's so much work.
to here.
Oh.
That's a lot of work. So you will see a lot of techs just starting off at 1672
Mhm.
and doing it at that distance, doing their AP obliques and their laterals and their open mouth.
Right.
Yeah. So it's more of practicality than theory why they do it that way. Small focal spot for what?
Better detail.
Better detail. Shielding. Okay. And again, we're just providing you with the info that you need to know. If we're shooting up here, you're not going to put a thyroid shield up on them, right? But
I hope not.
what about females? What do we need to protect?
Breasts.
The breasts. Okay. You guys have seen C-spines. Do you see anybody protecting the female's breasts?
No.
Okay. But they should.
I mean, yes.
But you should, okay? Medium range, a kV of 70 to 80 kV. AP versus PA. Is there a difference? And why should we even bring that up? I'm talking, well, not only angulation, but why would we prefer to do it PA versus AP or vice versa? Because what?
Thyroid.
Yeah. So if you're doing an AP, thyroid and breast is going to get a lot of the radiation from the primary beam. If we do it this way, it's less radiation to the thyroid and the breast. So theoretically, preferably, we choose to do it PA versus AP. But again, you're going to see them mostly done in an AP and even an AP oblique. Okay? Erect versus recumbent. You guys have this on your slide. I think I added this on. Okay? Erect versus recumbent. It is best to do the vertebral column in an upright position. In an erect position, we can see better alignment. Because of the weight that's bearing down on the spine, you see better alignment. Okay? And you can see any type of pathology that may be occurring in between the bodies, like intervertebral conditions like herniated discs. So it helps us evaluate the joint spaces a little bit better. Okay? You really can't get that out of recumbent. But if you have a trauma patient, which would be the better view?
Recumbent.
The recumbent. Okay? If they can walk, if they can talk, this is the best way to do it, is an upright. Okay? All right. So let's go ahead and do the routine gaze. First one here is an open mouth. So in an open mouth, you want to position the head while the mouth is open. Okay? Because the attempt is we're trying to line up the bottom of your upper teeth, the bottom of your incisors, to the base of your skull. This is known as the occlusal plane. So the occlusal plane is we're trying to get it perpendicular with the image receptor. Okay? As you guys already know, the whole purpose of doing the open mouth is to visualize the dens or the odontoid of C1. Wait. C2, yeah. What do you guys have?
C1.
C1, okay, so it should be the dens of C2. Okay, hold on. Let me fix this. Okay, everybody got that?
Mm-hmm.
Okay, so to see the dens of C2 and then the joint space between C1 and C2. So the zygapophyseal joint of C1, C2. Okay, you're only going to collimate, your image receptor may be this big, but we're only want to collimate to about this area, which is about a 3x3 or 4x4. Okay, are you guys collimating?
For that one we are, yeah.
Yes, okay, good. Okay, so you're collimating to 3x3 or 4x4. Okay, we're going to suspend respiration, hold still, don't move while you take the image. Okay, it's also probably also good to have them close their eyes. It helps. Have them close their eyes. Are we also going to shield our patient? We're shooting up here. Do we still need to shield our patients?
Sure.
Yes. Okay. You still want to shield your patient. So the atlas axis and dens are seen in its entirety. You're seeing the joint space between C1 and C2. The upper incisors should be superimposed with the base of the skull. Okay. No rotation is evaluated by equal distance of the lateral masses to the condyles of the mandible. So this should be even on both sides. Remember the spinous process we were talking about? This should also be right down the middle and even on both sides. Okay? Hold your breath, don't move, beep. Any questions on the open mouth? This is specifically to look at the dens and the joint space between 1 and 2. We can't see 3 all the way down. This is for the upper part of the cervical spine. Okay? And we do this because when you're doing an APC spine, you're not going to see C1 and C2 because of your jaw. So this is part of the AP study. Okay? And so here's your AP axial. Again, usually done at 40 inches. I think your book is going to tell you 40 inches. But due to practicality, you're going to have the text doing everything at 60 to 72 inches. Okay? Test purpose, what's the distance? 40 inches. Okay? So we're going to do 40 inches. The other thing that we're going to do is we're going to angle our X-ray tube approximately 15 degrees towards the head because of the curvature of the spine, the angulation is going to help open up the joint space. So we're going to do an angulation. This angulation, you want to center it right at the cartilage. Okay, you guys remember what the location of the cartilage is? What does that take you at the level of?
C3, C4.
C3, C4. So C3 and C4, find the thyroid cartilage. That's where you're going to direct your central ray. Hold your breath, don't move, don't breathe, don't swallow. Okay, because swallowing movement causes your neck to move. Okay? And proper positioning the head, same thing applies, is you want the tip of the mandible to base of the skull is parallel to the central ray. Oh, okay, mandible to base of the skull.
So it's
Okay.
going to match the
So
angle.
So this from here has to match the 15 degrees.
Mhm.
You're actually doing that with the patient's head when you're doing the
Oh, we
naked
have them
C-spine?
lifted, yeah.
Yeah, so you have them tilt up a little bit, okay. So these two planes have to match. All right. Occlusal plane and the mastoid tip are superimposed. Okay, same criteria as that of the open mouth. All right. So here we have an AP axial C-spine. We're not seeing C1 or C2. That's why we do the open mouth. Because of the jaw, we're not going to see it. So that's why we do the open mouth, a non-quick view. So what you will see, this may be a test question, is which cervical spine is demonstrated. Which cervical spine is demonstrated in an AP axial?
C3,
What are you going to tell me?
C3, C7.
Nope.
The T1 region.
To at least T1. Okay? So you want to see at least all the way to T1. Okay? So C3 all the way to T1, T2, T3, but you want to at least see T1 as part of that. Because when you know you've got the entire C-spine in there when you see
T1.
the adjacent structures. Same thing that we were doing. Remember we were doing the extremities?
Mhm.
We needed a baseline. We needed to know what we were looking at by looking at these adjacent structures. So same thing applies here. C-spine, C3 all the way down to at least T1. Okay? All right. So don't move, don't breathe, don't swallow. Collimate to the area of the neck. We don't need all this. Collimate to the area of the neck. Okay, questions? Wednesdays are always tough after those Tuesday classes, huh? For most of you.
Yeah.
Yeah. Nope. All right, obliques. Why would we do an oblique? What are we looking for in an oblique?
The interforaminal.
Intervertebral foramen, okay. So, again, we prefer to do it in an upright position. You're going to place your patient in a 45-degree obliquity. Okay, 45 obliquity. If we're doing a posterior oblique, which intervertebral foramina
Side
are we
up.
visualizing?
The other side.
So the side furthest away. So LPO we're looking at right, RPO we're looking at left.
Mhm.
Okay? Oblique your patient 45 degrees. I'm not looking this way at 45, I'm looking this way. So body is 45, but head is going to be lateral.
Yeah, we have them
Okay.
tilted up and then turn
Right.
around.
The purpose of turning your head is it removes the jawline from your spine. So that's the whole purpose of turning the head laterally. It moves it away from the spine. Okay? So 45-degree body obliquity and put the head in a true lateral position. We're going to keep the same angulation as the AP. Okay? 15 degrees towards the head in a posterior oblique, because again, we're trying to open up the intervertebral joint spaces. If you're doing an anterior oblique, it's an opposite angulation. Okay? Central ray is right in the middle of the neck at the level of
C3, C4.
C3, C4. Your landmark here is your Adam's apple. Okay? You're not going to see it here. You may see it here. Okay? But place the central ray at the level of the apple.